Dear session participants, you're very welcome to this session of the World Health Summit 2021 that is specifically focusing on rural health centers of excellence. My name is Rhoda Wanyenze. I'm a professor at Makerere University School of Public Health and also the Dean for the school. I'll be chairing this session with a colleague, Dr. Judith Van Housinger from EKFS. This session is really important at this time, especially as we are going through the pandemic. It focuses on exploring new ideas and new models of contributing towards universal health coverage in the rural areas in the low and middle income countries. This is so critical because these are some of the people that are most affected in terms of challenges in access to essential health services across the world. And we are delighted to have several speakers that have experiences working in these rural areas, and delighted to hear their experiences in working in these areas, in the rural areas with the most affected populations as we explore the approaches to the challenges that face these populations. I will hand over to Judith to take us through the organization of the session and also introduce the first speaker. Over to you, Judith.
Thank you, Professor Wanyenze. Also, good morning from my side. Isn't this a lovely start into the new week? Now, concerning this session, if you have questions for our speakers, we kindly ask you to share them via the chat function that you see in the program. And I think you're all used to using the chat function. We will collect the questions and we have secured time at the end of our panel to address them. And I would like to introduce our first speaker today, Dr. Gerald Mutungi. He will open the session with his presentation, Political Strategies to Achieve Universal Health Coverage in Rural Uganda. Dr. Mutungi is the Assistant Commissioner for NCDs at the Ministry of Health in Uganda. He is a medical doctor and a public health specialist with a master's degree in public health. He has headed different programs at the Ministry of Health headquarters in Kampala. He has traveled extensively to contribute to global policies, guidelines, and other documents for the prevention and control of NCDs, including monitoring. Dr. Mutungu, the floor is yours.
Thank you very much, colleagues, and I'm happy to be here to present this presentation. I must say that I'm not a politician, so I'm a civil servant. So when you see political strategies for UHC in rural areas of Uganda, you may think this is being presented by a politician. I'm not. I hope I'm able to share my screen. Are you able to see my screen? Hello?
Yes, we can see very well.
Why am I failing to put in the slideshow? Okay. So I'm happy to present the political strategies for universal health coverage in rural areas of Uganda at this World Health Summit being held in Kampala. For our audience who may not have heard about universal health coverage, in a brief, universal health coverage is defined as availability of quality and affordable health services for all without financial impoverishment. It is centered on improving equity, efficiency, and financial protection while ensuring quality of the services. The overarching goal is to reduce the incidence of catastrophic health expenditure, which contributes to poverty alleviation and economic development. Uganda, we are committed to universal health coverage. We are a partner in the Global Development Agenda for Universal Health Coverage 2030 as under SDG 3.8. The Health Sector Development Plan seeks to, among other goals, to accelerate movement towards universal health coverage. Universal health coverage is also encapsulated in overall targets of the country's Vision 2040, which is our roadmap. It's called Uganda Vision 2040. The context of UHC demographics, the 2021 projected population of Uganda is about 41.6 million, and 74.5% of the population resides in rural areas. So it's this presentation is very important. We are looking at the rural areas where 74.5% of the population reside. And only 35.8% of the population can access affordable medicines and vaccines on a sustainable basis. Coverage, again, urban areas is 69%, but our rural areas is much lower. Primary health care services are provided predominantly through public institutions. We have community health workers, we call VHTs, or village health teams. They provide significant support for primary health care, especially in rural areas where the population of skilled workforce is lower than that of urban areas. Governance for universal health coverage. This is underpinned by the laws and interactions across diverse stakeholders with varying degrees of influence. The state and its designated organs provide policy direction, oversight, and resource mobilization, and they're also responsive to citizen needs. The key players in this, we have Ministry of Health and other government ministries. We have UN agencies. We have donor agencies, our development partners, but also implementation partners. We have professional councils, academic and think tanks. We have civil society organization, and we have advisory working groups and technical working groups that form part of the governance for our universal health coverage. What are our policies, programs that talk about universal health coverage? We have a liberalization policy. That's why we have the private sector contributing almost half of our health services. We have the decentralization policy where services, primary healthcare services are decentralized to the district level. We have a national health policy and health financing strategy, and all these talk about universal health coverage. Our pro-universal health coverage policies, I've mentioned the liberalization policy. The policy allows for private sector players and encourage partnership with public sector to provide health services. The public health facilities make up 5% of the total healthcare facilities in Uganda, while the private not-for-profit and private for-profit make up 16 and 29 respectively. Although almost 90% of the private for-profit health facilities are in the central district of Kampala, the capital city. Then our decentralization policy in 1987 put the crucial services nearer to the people and controlled by the district leadership. Our national health policy, which operationalizes the health sector strategic plan 1 and 2, ensures access to minimum health care package by subsidizing the designated public health and essential clinical services that have visible consequences for the community. We abolished user fees in 2001 in all government health facilities, except for the private wings in the hospitals. We operationalized this was operationalized through implementation of the health sector strategic plan of those years, and include the establishment of the national health insurance and other community health financial mechanisms and strengthening of intersectoral collaboration and partnerships. We have seen, or when we have abolished user fees, where patients had to contribute some money when they come to our health facilities, we realized the impact. Improved access to the services, and that of poorest household benefited the most. That was published in that paper. There were efficiency gains with increased use of lower level government health centers. There was also an increase in per capita outpatient attendance, which ranged from 0.4 to 0.72 and increased to 0.79, and I think now we are at 1. It means every Ugandan on average attends at least an outpatient clinic in a year. We realized near universal coverage of antenatal clinics and expanded program on immunization, increased the coverage. For example, for DPT3, it increased from 55% to 83% in that year. So we have what we call Uganda National Minimum Health Care Package that every Ugandan at least is entitled to. And it is a cost-effective venture that government established to guarantee free access to a set of health services, such as childhood immunization, health promotion and education, as well as treatment and control of common non-communicable diseases, infectious diseases such as malaria, HIV, and tuberculosis. The Uganda National Minimum Health Care Package was implemented by our Health Sector Strategic Plan 1, but due to some bottlenecks in implementation, such as inadequate level of prioritization, inadequate investment in critical inputs, piecemeal implementation, and poor coordination, most of the targets were not achieved. As such, under our Health Sector Strategic Plan 2, the package was grouped into four clusters. Cluster 1 is health promotion, disease prevention, and community health initiatives. Cluster 2 is maternal and child health. Cluster 3 is control of communicable diseases. And cluster 4 is control of non-communicable diseases for easy coordination and monitoring. We have challenges in implementing our national minimum health care package, mainly because of budgetary constraints of trying to achieve universal access with our about USA $8 per capita rather than the recommended 28. And most of the package available under this package was predominantly available at health centers and hospitals. And health centers and hospitals are not near to the communities. We would want these packages to be at the community level, health center 2, health center 3, but because of those constraints, the package is mainly at health center 4 and hospitals. And our people really live in rural areas far from these facilities. And the transport costs sometimes stop them from coming to enjoy these services at higher levels. We have our health financing strategy, which established social protection insurance for 30% of the population by 2025. That was our vision, that we shall have at least 30% of the population insured or having social insurance, health insurance by 2025, but this may not be achieved because, again, of many issues, including political issues. We wanted to upgrade the minimum health care package, which mainly concentrated on communicable diseases, to a comprehensive essential service package. Now that we have a global burden, a growing double burden of communicable and non-communicable diseases, and this has been partly achieved. So these are our indicators as of now. At least 72% of the Ugandan population live within 5 kilometers of health facility that tackling the equity, but only 13% of health facilities carry out scheduled maintenance of medical equipment. So when we did this, most of the medical equipment are non-functional. Health workforce is at 1.55 per 1,000 population. The health facility reporting availability of over 95% of the basket of commodities is only 55%. So meaning that most of our health facilities have stockouts of essential drugs. Only 37% of the hospitals offer intensive care services, and 38.4% incur out of pocket expenditure. It means even when we have a very free health services in our public health places, a significant number of our population incur out of pocket expenditure when they're accessing these services. As of now, we don't have yet a community health insurance scheme. Some progress made in the sector, but it's still below the target really to meet our vision 2040 as earlier indicated. What are recommendations? The government health policies should deliberately shift their emphasis from planning to health-based, from planning for health-based based on curative care to planning to promote health. Because most of our budgets now are in hospitals for curative services, little is done to promote health. So we think we should change this approach. The government through Ministry of Health and Office of the Prime Minister should endeavor to holistically promote health by emphasizing intersectoral collaboration across other sectors, education, water and sanitation, road and works, agriculture, because most of the social determinants of health actually fall outside the health sector. The government should, through Ministry of Health, strengthen the regulatory accountability and enforcement mechanism at all levels and across different players in the health sector. Coordination and zoning of health development partners. We have many development partners. Sometimes they compete in one area. We think we should allocate or zone, and each development partner is responsible for one place. The government should strengthen community governance systems. We have not gone to the community yet, and I'm happy the access, we'll talk about access to health services in the rural communities. The National Health Insurance Scheme has potential for improving risk pooling and increasing coverage of the population through the creation of integrated risk pool, thereby reducing the current fragmentation. Significant increase in the budget allocation and other resources are needed to serve the target population, especially the rural vulnerable groups. And dear Chair, that ends my presentation. Thank you very much for giving me this opportunity and the audience for listening to me. I'm waiting for questions. Over to you. Thank you.
Thank you, Dr. Mutunji, for your very insightful presentation on political strategies to achieve universal health coverage in Uganda. We are now moving on to the presentation from Dr. Peter Jackson, and his presentation will focus on research and training partnerships for the prevention and control of non-communicable diseases in rural areas in low and middle-income countries. Peter Jackson is a medical doctor and an assistant professor in the Division of Pulmonary and Critical Care at the Virginia Commonwealth University. His research focuses on non-communicable lung disease in low and middle-income countries with a focus on East Africa. In 2019, Dr. Jackson was awarded an NIH Fogarty Global Health Research Fellowship with Johns Hopkins University, during which he lived and worked here in Kampala in Uganda, and conducted multiple research projects that included investigations into the cause of restrictive lung disease in sub-Saharan Africa. Dr. Jackson, we are delighted to hear your presentation, and the floor is yours.
Excellent, thank you. Let me see if I can share here. Can everybody see my slides?
Yes.
Great.
Yes, we can see them.
Excellent. Okay. Well, first off, I just wanted to thank everybody for being here and say good morning. It's 2:30 in the morning here in the United States. So if I make mistakes, please write me an email and I'll try to fix them. But I'm very excited to get the chance to speak about our partnership and research to combat pulmonary non-communicable disease globally. And I'm going to focus on rural centers of care. I have no pertinent disclosures. And I do have my email here. If anybody wants to get in touch with me, please reach out. So today I'm going to talk about combating non-communicable lung disease in rural low middle income settings. And I'm going to first talk about an overview just of pulmonary non-communicable disease in these settings. I'm going to talk about some risk factors that are specific for rural settings in low middle income countries. And throughout all of this, I'm really going to be focusing mostly on chronic obstructive pulmonary disease. There's a couple reasons for that. One is that most of the research in this area is focused on this disease entity And also it really contributes to a large amount of the burden of non-communicable respiratory disease in the world. And I'll be touching on the challenges with treating respiratory non-communicable disease in rural regions, and then talk a little bit about the solutions that we've come up with. So many people are probably familiar with some of these statistics, but I think it helps to kind of frame the talk. So non-communicable disease are the leading cause of death globally. And the top 4 non-communicable diseases, which are cardiovascular disease, cancer, respiratory disease, and diabetes, account for 72% of all deaths, and 85% of those occur in low middle income countries. I think that's represented well by this graph, which actually shows the disease burden as measured by disability adjusted life years. And you can see that over time from 1990 to 2017, there's been a decrease in the overall amount of communicable diseases, which is highlighted in red, but an increase in non-communicable diseases contribution to disability adjusted life years. Chronic respiratory disease has really rapidly increased in prevalence. And this is nicely shown here. So on the left, well, these are ranks of causes of global mortality. And on the left, you have the diseases ranked in 1990, and on the right, you have them ranked in 2019. And you can see that cardiovascular disease and neoplasms represent the #1 and #2 causes of death throughout the world, but they remain stable. But you see that chronic respiratory disease went from the 6th leading cause of death to the 3rd leading cause of death globally over that 30-year period, really highlighting the need for research in this area. I'll have a caveat here, which is when I was preparing for this talk, a lot of the research on the increased prevalence of non-communicable disease really focused on urbanization. So there's kind of a lack of research on the disease burden in rural areas of low middle income countries. But I'm going to try to pull from the research we've done and research other people have done and kind of highlight the rural aspects of that work. I mentioned that I'm going to talk a lot about obstructive lung disease, so I think it's helpful to just kind of go through what that is. Chronic obstructive pulmonary disease is characterized by the inability to exhale air in the same way that others can. And this is measured with pulmonary function testing, and you'll see some research about that. What happens is that people, if you inhale particulate matter or smoke, you will end up damaging your airways. And you can see a healthy airway there on the left, and then a damaged airway on the right. And you get thickening of the epithelium inside of your airways, and that leads to mucus trapping and the inability to exhale air. You also will damage the sacs, the alveoli that transfer oxygen to your bloodstream. And this can lead to low oxygen in the blood. And it leads to symptoms like breathlessness, cough, sputum production. And then at the extremes, it can cause death. The primary treatment we use for chronic obstructive pulmonary disease are inhalers. Usually inhaled corticosteroids are started relatively early, and that's one of the key medications that should be available according to the WHO. There are specific risk factors in low middle income countries in rural settings that really lead to pulmonary disease. This is a picture I took when I was living in Uganda, and this is a home that did coffee production, and you can see that they're burning wood here in an unventilated area, and you can see smoke in the air. And so this biomass smoke exposure is linked to a number of diseases. It can cause lung cancer, COPD, which I'll touch on quite a bit, asthma, and cardiovascular disease, as well as diseases in the pediatric population, which I won't discuss. I'm an adult doctor, so I'll focus more on the adult side. Our group has investigated the differences in rural and urban areas when we look at the particulate matter and carbon monoxide inside of homes. So this is work done by Susie Pollard, who's now at the NIH and was with us at Johns Hopkins. And she looked at particulate matter and carbon monoxide, those graphs are not shown, over time in homes in rural settings and urban areas in Peru. And you can see that as you go through the day, around 6 a.m. and 6 p.m., you see these large spikes in particulate matter in the rural homes with chimneys and without chimneys. And that's related to the time at which they're cooking meals. So obviously there's a lot more exposure within the home to this type of smoke. Cigarettes are a risk factor for almost every pulmonary disease, and they're a risk factor for almost every non-communicable pulmonary disease. And even though we think of that being more common in high-income countries, they're readily available in low-middle income countries. This is work by a group that is not affiliated with me. And you can see that the availability of outlets selling cigarettes and the access to cheap cigarettes was very high in low-middle income and low-income countries. It was not necessarily higher in rural settings, but it was certainly higher in those rural settings than it is in high-income countries. So again, just highlights the concerning trend in these settings. Given all that exposure, it may not be a surprise that COPD rates seem to be higher in rural settings in low-middle income countries. This is work done by my colleague Trishul Siddharthan, and it was a cross-sectional population-based cohort study where we did breathing tests on 1,500 patients, subjects, excuse me, in Uganda. 837 of those were in Nakaseke, and 665 were in Kampala. And you can see on the leftmost side of this graph that there was a significant increase in the prevalence of COPD in rural areas as opposed to urban areas in the light gray. While COPD is more prevalent, the treatment is also more challenging in rural areas. Another person in our group, Nicole Robertson, conducted a qualitative study where she interviewed 16 urban and 10 rural healthcare providers in Uganda and asked them questions related to their knowledge about COPD and their comfort in diagnosing and treating COPD. And she found that the providers in Nakaseke had significantly less knowledge and comfort treating COPD. Besides knowledge, there's also a lack of medications. This was touched on a little bit with the speaker before me, but in this study, this was not done by us again, but they utilized the Ugandan Service Availability and Readiness Assessment data from 196 health centers. And they found that when they looked at the medications that are listed by the WHO as essential, the least common one in pharmacies was an inhaled corticosteroid. Only 1.5% of facilities in rural Uganda had that. So it's really just shows that we're lacking those treatments. We did a similar study looking at 3 different sites in our GECKO cohort. This involves a site in Nepal, one in Peru, and then in Nakaseke. And so I'm comparing data across countries, so there are obviously caveats about this. But what I will say in regards to the topic of this presentation is that Nakaseke was the only rural site. And we looked at availability of medications for treating COPD. And you can see the highlighted section that there were no medications for treating COPD with the exception of SABA, which stands for short-acting short-acting beta agonists. And those are really treat only the most mild cases of COPD. So again, really a lack of availability of medications. We also looked at cost. I don't have that data, but I do have the numbers there at the bottom bullet point. And to treat severe COPD in Nepal would cost 2.38 days of wages, and it would cost almost 2 months of wages in Uganda. So real challenges in treating this disease. Besides COPD, there are a lot of other non-communicable respiratory diseases, but they're not as well studied. But there's reason to feel like we should start to investigate them. So this is, again, data from the LINK cohort, the cohort where we looked at Nakaseke and Kampala. And aside from the obstructive pattern that we saw on pulmonary function testing, we also saw restriction. Restriction means that you can't get air into your lung. And that can be due to fibrosis or scarring, inhaling pathogens or molds, Sometimes people who are involved in mining and inhale rock dust, stuff like that, can have a pattern that appears this way. And you can see that there's a very high rate of restrictive spirometry among this cohort. And when we adjust for age, it's actually slightly higher in the rural setting. Again, that wasn't statistically significant, but it's certainly there. This was also seen in Malawi. So this is Kevin Mortimer's group. And they saw restrictive findings, again, that one that might be fibrotic, in up to 50% of individuals 18 to 29-year-old in Malawi. This was mostly urban. They didn't distinguish rural and urban, but the takeaway here is that there are other pulmonary diseases that seem like they may be prevalent and need more investigation. This was really the subject of my Fogarty Fellowship when I was living in Uganda, but unfortunately a lot of that has been held up because of COVID. So we're trying to assess that by looking at COPDs and longitudinal data. One reason why I think this might be occurring is due to post-TB lung disease. I know this is a non-communicable topic, so I won't talk too much about TB, but this is a CT scan of somebody who had tuberculosis and then was cured. But you can see all the scarring that's left behind from tuberculosis. And that can lead to a restrictive pattern. And it really warrants increased investigation in how we might prevent that.
Dr. Jackson, may I kindly ask you to conclude in the next 3 minutes? Yes,
I'm almost done. It's kind of impossible to not mention COVID. So this is the elephant in the room. This is data from tuberculosis clinics that I'm actively investigating right now. I only use it to say that in the Wakiso district, which is a more rural district in Kampala, there was a significant reduction in the amount of people who could come to clinic. And I think that that's very, very worrisome. And I'm concerned that may also be true for those getting care for non-communicable disease. So how can we improve this care? One, we need ongoing research to identify gaps and implement solutions. We have a randomized controlled trial looking at theophylline, which is very cheap and readily available for biomass COPD, and we're studying that in Uganda. We don't have results, but that could be a real game changer in how we treat these diseases. We need policy implementation to improve access to medications and care. I think the first speaker did an excellent job about talking about all the steps that the Ugandan government is taking, and I know that's happening across the world. And then we need to train experts in pulmonary care. So this is our developmental grant that we're doing with Johns Hopkins and McRae to train pulmonary experts. This is a grant from the NIH, and we intend to train 17 experts in pulmonary disease and have 180 attendees per year to learn about research in non-communicable disease. It's a list of some of the different projects that our trainees are doing. And it's a really, really exciting, exciting grant and an exciting program. So that's it. I just wanted to say thank you, and I'll turn it back over to everybody else.
Thank you, Dr. Jackson, for your very inspiring talk and your impressive knowledge on COPD treatment and other pulmonary NCDs in rural areas and low resource settings. And also thank you for keeping the time. I would like to introduce our next speaker, Dr. Robert Kalia, who will discuss the role of community health workers in NCD care. Dr. Kalia graduated from Makerere University College of Health Sciences with a degree in medicine. He later undertook a nephrology fellowship at Yale University. Dr. Kalia currently works as a consultant nephrologist at Mulago Hospital and as a lecturer at Makerere University College of Health Sciences. He is the president of the local organization Access Uganda and the local PI for NCD studies. His major interest is understanding how community health workers can contribute to improved health in rural areas. Dr. Kalia, the floor is yours.
Thank you very much for the wonderful introduction. I'm going to be talking about rural health centers of excellence.
Is it because you are in the rural center?
African Community Center for Social Sustainability. Hello?
You were breaking, but we can now hear you. We can now hear you.
You can now hear me?
Mm-hmm.
Okay, thank you. So that's the talk outline, and the area we work in is located in Nakaseke district, which is about 64 kilometers from Kampala. And the access mission is really to work with vulnerable people in resource limited settings through provision of medical care, education, and economic empowerment. And we pride ourselves in involving the community at large. These are our major activities. We basically deal in healthcare, education, and economic empowerment. This is our model. Our model actually begins in the community. Our foot soldiers are community health workers who actually reach out to the rest of the community. The different programs are actually based on the community health workers. We have the community health workers who support orphans and vulnerable children. These orphans and vulnerable children can have preschool education, and then they can go on to conventional schooling. We also have a nursing school. For those who are not able to go to university, they could also go to the nursing school at enrollment level. And then those who drop out a little earlier, we do skills building and we give them skill sets. We also have a nursing school that actually gives certificates in nursing. And the last component is actually based on research. So our center, and we use them to do a lot of activities. This is a picture of our graduates. We have now been in operation for 5 years, and this is our center, the Access Life Center. In collaboration with the Charity University based in Berlin.
Dr. Kalia, perhaps you could take off the video.
Yes,
maybe it will help. Perhaps you could put off the video. Maybe it will help. You're breaking sometimes.
Okay. All right. Thank you, Prof. So the project I'm going to talk about is integrating and scaling up NCD services in Nakaseke district using the community-centered model. Yes. So in 2016, we got a grant from the EKFS that actually helped us to train community health workers. And these community health workers were taught in the management of non-communicable diseases. And they actually make the community visits and then conduct medical education to the community to raise awareness about non-communicable diseases. Awareness of non-communicable diseases by then was very limited in the Nakaseke district. In 2020, we got another award, which is a 3-year award. And in this award, we are going to capitalize on what we did already to see that on top of having community health workers do the care and management of patients, we can also educate them to have some form of task shifting to help and improve NCD care in rural areas. As I said earlier, the community health workers initially were able to screen NCDs in about 16,000 people. These were self-reported. And we also set up a community education project, which is called the Pocket Doctor. Here you can see the community members using this small book. The book is arranged in such a way that on the right, you have pictures that show what is in words on the left, so that people are able to see and appreciate what the risk factors are, what they can do to prevent disease, and how they can help other community members fight this epidemic. So these are photos of community health workers, as well as the health workers who were trained at Nakaseke Hospital. We use the curriculum of the Ministry of Health to train the health workers. And then we also developed a curriculum for training community health workers in the management of the non-communicable diseases. So the patients also play an active role. They actually participated in the development of these books, and they were also very useful to them when the evaluation was done. So in strengthening the non-communicable disease management, the key component is ensuring that the community health workers have enough information, the health workers have enough information, and then also work with the key bodies like the Ministry of Health. We've worked very well in collaboration with the Ministry of Health, but the training has to be very thorough, and we take 5 days in training and an extra 5 days of following up and ensuring that the community health workers learn how to do stuff. We also have a component of global health where we have international fellows paired up. On the left, you can see Dr. Munana, who is our fellow from Uganda, and on the right, Katarina, who are actually actively involved in educating the health workers, educating the community members, and also ensuring that we provide up-to-date healthcare to our program is really to develop the research capacity. We have had several partnerships with key stakeholders, and have done several publications, as you've heard Peter speaking, most of them based on the respiratory system. But we have also done some studies to characterize the role of community health workers in the management of diabetes and hypertension. And now we are in the final stages of initiating an RCT to assess the effectiveness of a multi-component, looking at CHWs in the care of blood pressure and blood sugar. This is the task shifting RCT that we are going to see. We have also set up a community advisory board. This one brings in ideas from the community and actually ensures that whatever we are doing continues to be of benefit to the community. The community advisory board is multidisciplinary. It has members from the Ministry of Health, particularly the district. We have community members, community health workers, and then also health workers from key partnering institutions. So this has actually been very good because they always give us feedback, and we have had so far 4 meetings, and their input has been very wonderful. We have done this work in partnership with several partners who have been very instrumental in ensuring that our work continues well. This is the EKFS, Charity University, the Ministry of Health, Makerere University, the UNICD, and a lot of other partners. This ensures that we do sound science, as well as ensuring that we deliver the up-to-date health care using the standards that are available within the country to our beneficiaries. I want to thank you very much for listening. Sorry for the background noise. Thank you, Chair.
Thank you, Dr. Kalia, for your enriching perspective on community-based initiatives for strengthening healthcare in the rural setting, which is very critical in the low and middle income countries. Our next speaker is Dr. Harold Nasser. Dr. Nasser heads the Global Patient Solutions at Gilead Sciences, a team that is responsible for the leadership of the Gilead portfolio in more than 120 countries in Central America and Caribbean, Eastern Europe, and Central Asia, Africa, as well as India and Southeast Asia. Access to and affordability of medicines is a priority for this unit. Besides, he is a global ambassador of the G20 Health and Development Partnership. And until the spring, Dr. Nasser led the Novartis social business. He served on the board of the UNITA-hosted Defeat NCD partnership in its inaugural year. Prior to this, his engagement with Novartis, through his engagement with Novartis, he has been leading the Bayer healthcare business in 48 low and middle income countries in Asia, Sub-Saharan Africa, and Latin America. Dr. Nasser, we are looking forward to your presentation on the role of pharmaceutical industry towards universal health coverage. The floor is yours.
Thank you very much. Good morning, good afternoon, and many thanks to include me in such a great panel. So my discussion is going to be a little bit on communicable diseases, but I am advocating to flex the notions of communicable diseases and non-communicable diseases, as several communicable diseases indeed require chronic medication, adherence counseling, and decentralized care, much like non-communicable diseases. Therefore, synergizing patient-centric interventions at community level is the key to a strengthened, more resilient health system. So what is, let me advance this. So what is Gilead's Global Patient Solutions about? The GPS team, which I'm heading, works to reverse health inequities by overcoming barriers to treatment and care in low middle income countries. That means we look at two things at the same time. On one hand, we concentrate on a usual pharmaceutical business. That is 50% of the attention that we spend. The other 50% goes in trying to work within the system, trying to program health systems engagements and interventions which help to progress toward the Sustainable Development Goals. We do this, of course, with a priority on the portfolio from Gilead Sciences, which predominantly is in viral hepatitis and HIV. So we see that in the territory of Global Patient Solutions, many diseases and many patients fall into this, with living with those diseases. For example, nearly 90% of all people living with HIV are part of the GPS territory. I'm not going to read all of this to you. I'm trying to mention that, of course, with viral hepatitis B, for example, you are very likely to develop chronic hepatitis, and with that also a high likelihood of developing hepatocellular carcinoma, which indeed would then be qualified as a non-communicable disease. So all those are intertwined in a way, and a strong health system will help overcome some of those barriers to access to not only treatments, but to critical health services across the continuum of care. What have we done in the past? And no worries, I'm not going to go into each of those interventions, but I guess when you look at the continuum of care, starting from the disease burden, awareness, stigma, over to prevention, diagnosis and testing, referral, treatment, follow-up, continued care, and eventually a good control of a disease or even elimination, then there are different points where a private organization can meaningfully intersect. And let me start by mentioning 3 of those programs we have been engaging in the past, but they focus selectively on different points of this care continuum. The DREAMS program, DREAMS stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. This DREAMS partnership is an ambitious public-private partnership aimed at reducing rates of HIV among adolescent girls and young women in the highest HIV burden countries of sub-Saharan Africa. It significantly catalyzed the uptake of integrated HIV prevention services in Africa in all of the at-risk populations. When then looking at the CARP-T, this is a community-based ART for children and adolescents in rural Zimbabwe. Challenges in pediatric treatment include stigma. It includes dependence on caregivers, access to youth-friendly health services, and enhanced adherence counseling. Stigma and incomplete adherence may be mitigated through differentiated service delivery models of community-based antiretroviral therapy. We supported this differentiated service delivery model at Chitamoyo Christian Hospital, a rural mission hospital in Hurungwe district in Zimbabwe. And what we see is, first, it reduces time, transportation, and costs. And second, the viral load suppression can be optimized through deployment of point-of-care molecular diagnostic testing. And last but not least, as an example from this chart, the hepatitis C micro-elimination in Arkangai. The liver disease-free Arkangai in Mongolia project was conducted in collaboration with the Arkangai Province Health Department, with the goal to reduce morbidity and mortality levels of viral hepatitis among the Arkangai population. In this population, the liver cancer has caused almost 50% of total cancer mortality rates over the previous years. In December 2016, this Arkangai Province Health Department in Mongolia and Gilead Sciences initiated this liver-free disease project amongst adults between 40 to 65. It showed excellent results, with 82% of the target population having been screened for viral hepatitis C. 98 of those eligible patients for treatment were linked to care, and of those that completed treatment, 99% had been cured. This demonstration project can serve indeed as a model for HCV microelimination. Particularly important to the success were that locals executed the entire project and the interventions targeted high burden subpopulations. This is a busy slide and I'm not expecting you to read all of this, but what it shows definitely is that of the 160 million people living with hepatitis B, only 3.8% are diagnosed. 3.8% only. Out of those 3.8%, only 2.8% are treated. That is less than 1% of chronic hepatitis B patients receive treatment overall. That results in 200,000 annual deaths caused by hepatitis B. And those are people in their most productive age, very similar to the non-communicable disease burden. And of course, you could argue 200,000 annual deaths, this is little compared to the death toll of malaria or even hypertension. Given the low diagnosis rate, focus on prevention, still very similar to the situation with non-communicable diseases, focus on prevention of mother-to-child transmission and the option to synergize in prevention and to synergize across disease areas and vertical interventions is very key. As we all know, the biggest bang for the dollar invested, the biggest social bang for the buck is in preventing treatments from occurring or preventing mother-to-child transmission. Healthy diets, for example, when it comes to preventing diabetes, preventing hypertension, and all the fatal results of hypertension. So what I'm arguing for, in those settings where already interventions happen, we can indeed look into preventing mother-to-child transmission, not only for hepatitis B, but also for HIV and for syphilis through a very well coordinated awareness creation, testing, linked to care, linked to treatment, and follow-up program. That follow-up includes then the differentiation between the question of whether and to what extent the mother's viral load can and must be suppressed going forward. And secondly, of course, the necessary early vaccinations and the first birthday dose of the newborn.
Dr. Nussar, may I kindly ask you to conclude in the next 3 minutes?
It's my last slide. Yes, thank you. So what the key is, and the integration of learnings is, that coordination is key, that different partners increase the effectiveness, various partners, and that implementation and executions need to be local. The importance of measurement of predefined activities, outputs and outcomes is crucial and needs to be linked with surveillance systems. Demedicalization can be achieved through including stigma mitigation into the design of decentralized differentiated service delivery and enhanced adherence counseling. Synergizing rural implementation work across national health priorities as we treat people and not diseases. It is important, and I want to really stress this, monitoring and evaluation is key, and looking at real outcomes. And in those boxes here on the very bottom of the page, some sample metrics at different points of the pathway of care I have put forward. They need to be measured and continuously, transparently read out, not only to the partners, but to the general public. Thank you very much.
Thank you, Dr. Nussar, for highlighting the important role of pharmaceutical companies in driving universal health coverage, and also for showing us on how to reach people across the care continuum in low resource settings. I would like to introduce our last speaker for today, Dr. Valerie Likes. Dr. Likes is a medical doctor currently practicing as a nephrologist in Switzerland. She is trained in internal medicine at University of Miami and in nephrology at Harvard Medical School. She has an MSc in public health in developing countries from the London School of Hygiene and Tropical Medicine, and she has a PhD in biomedical ethics. Dr. Likes further holds affiliate positions with the renal division at the Brigham and Women's Hospital, Harvard Medical School, and the Department of Child Health and Pediatrics at the University of Cape Town. She has been a consultant to the World Health Organization as well. Her research activities include the challenges of justice, equity, and moral distress relating to resource allocation and management of non-communicable diseases in low and middle income countries. Dr. Likes will today contribute to our session with her talk on ethical implications for sustainable management and NCDs in resource-limited settings. Dr. Likes, the floor is yours.
Okay, thank you very much. So as mentioned, I will be discussing a little bit about ethical implications for management of non-communicable diseases. Very briefly, I don't have any disclaimers. I am an advocate for equitable access to quality care based on my experiences all over the world. I originally come from South Africa, but at present I am based in a high-income country. So the objectives quickly are to discuss why NCDs are important, some existing inequities, to review the obligation about prioritization of NCDs, and then some strategies to improve NCD prevention and care. So as we all know, NCDs have suddenly taken center stage because they are high-risk factors for poor outcomes in patients with COVID. And this has actually brought to light the fact that NCDs have been very much neglected practically worldwide until recently. And this slide really looks at the total global deaths. And as we already heard from Dr. Jackson, non-communicable diseases are causing the major amount of deaths in the world. But if we then look at the development aid for health, we can see that only 2% of funding to low and middle income countries for all diseases has gone towards non-communicable diseases, despite the fact that these are the greater burden of disease. So there's an enormous inequity here between funding and disease, actually prevalence and burden. We know, for example, that the Global Fund, which was started in 2002, has been wonderful in terms of fighting AIDS, tuberculosis, and malaria, and 32 million lives have been saved since then. But AIDS, tuberculosis, and malaria are not the only disorders. And as you can see here, there are in the middle an enormous amount of social determinants of health, which were mentioned by Dr. Mutungi and other presenters, and strong interactions between these infections and non-communicable diseases. So we actually need integration of care, and we need funding for all diseases if we are to try to reduce the global burden of disease. So we can't only focus on non-communicable diseases, we can't only focus on communicable diseases. What we also know, and we heard about this from Dr. Mutungi and from various others, that the odds of catastrophic health expenditure is very high for non-communicable diseases. In some studies, there was one from Malawi, which showed that it took 18 days of work for someone to actually pay for 5 cardiovascular medications every month, which is impossible. And these studies are from various parts of the world, but you can see on the right-hand side that there is a very high incidence of catastrophic health expenditure in patients with non-communicable diseases, because very often the medications are unaffordable, and patients need to pay for these medications often out of pocket. They sometimes need to pay also for access to clinics. They need to pay for transport to the clinics. This needs to be done on a regular basis, as non-communicable diseases require long-term care, and therefore this is a very big problem. And as Dr. Mutungi mentioned, we need to get these under the umbrella of universal health coverage. What we also know, and I think Dr. Mutungi did mention, that the use of healthcare centers has gone up since they abolished user fees. But the one other big important question, which he also alluded to, is the importance of focusing on quality. And this is a very good study from Margaret Kruck at Harvard, who actually looked at the 15.6 million excess deaths in low and middle income countries in 2016, which were due to non-communicable diseases. In this study, around half of them could be prevented by public health interventions, which really stresses the critical opportunity we have with good public health and attention to social determinants of disease to reduce the burden of non-communicable diseases. But significantly, 8.6 million people had actually non-communicable disease deaths which were amenable to healthcare, meaning they could have been prevented. And here, 5 million of these, which are in blue, deaths were actually attributed to poor quality. 3.6 were attributed to non-utilization. So these 5 million actually somehow got to a clinic or got to a hospital, but did not get the correct care, and that is why they died. So quality is absolutely critical when the patients themselves are actually then trying to pay and trying to access the care. So a colleague and I from Argentina tried to go through this thought process. Why have infectious diseases been prioritized? As I showed you, there was so little funding allocated to non-communicable diseases since 2000. So we thought, well, infections are preventable, they're acutely reversible, they're curable, they're controllable, even, for example, now HIV, they're contagious. And so as we know also from COVID, you know, they impact others. Treatment is often cost effective because you only need antibiotics for a couple of days to save a life. It does affect the most vulnerable, and still communicable diseases are the primary causes of death in many very low income settings. Individuals are often not to blame. It's often also more poverty and circumstances that lead to infections. Infectious diseases are amenable to vertical programs, as the Global Fund has shown, with malaria, TB, and HIV. And because it's easy to measure outcomes, they're a quick win for donors. So we thought, okay, we understand why there's been a priority for infections, but we then tried to go through this thought process for non-communicable diseases, and I'll come back to this. So what we do know, and what we've heard this morning, are that non-communicable diseases are complex. And as Dr. Kalia showed, you really need a very holistic approach to this problem. There are underlying drivers, which are social determinants of health. There are individual modifiable risk factors in the people themselves. There are metabolic and physiologic indicators, which we need to detect and treat early so that we can try to reduce the burden of NCDs. The World Health Organization initially put forward this 4x4, which was cardiovascular disease, cancer, chronic respiratory disease, and diabetes, adding up to the leading causes of non-communicable diseases and deaths. They have now subsequently added mental health, but the huge question is these are not the only 5 NCDs, and so what about all the others? Another very important factor, and this has been mentioned because of the social determinants of health, is that NCD risk begins in fetal life and is impacted every day. And so there are factors which occur throughout the life course which impact a risk for NCDs, whether these are detected early and treated and how they progress. And basically, as we've also heard, the social determinants of health are all targets of the Sustainable Development Goals. The Sustainable Development Goals have one health goal, but the other 16 goals are all related to reduction in poverty, improving access to care, improving access to good work, to healthy environments, etc. And so it is absolutely critical that all of these 17 goals are targets in order to prevent and improve access to care for non-communicable diseases throughout the life course. We can't forget the babies with healthy mothers and the elderly who often tend to get neglected. Another aspect is that we know that prevention works. We know that prevention is highly cost effective. There is a lovely online publication about this for non-communicable diseases showing that if we invest $1 now, we will gain $7 by 2030. And the WHO and many others have very good and easy to follow guidelines for all sorts of health income countries. And so we know what to do, and we know that we should do it. So now coming back to our analysis about the moral justification of prioritization of infectious diseases, we decided to ask ourselves the same question for non-communicable diseases. So yes, non-communicable diseases are preventable. There are several that are acute and reversible. There are several that are curable. Many are actually controllable with good access and even cheap medication. Some are contagious, and here we're using the word socially, environmentally contagious. We also heard this presentation about indoor cooking and all these causing respiratory diseases, so they are contagious, even if it's not an infectious agent. The best buys I just mentioned show that it is cost effective to try to prevent and treat NCDs early. It definitely affects the most vulnerable. As we've heard, the patients in the rural settings have even less access to care and a high burden of NCDs. Individuals are often not to blame because the social determinants of health are major contributors to NCDs. The problem is that NCDs, because they are so complex and cross-cutting, are not amenable to vertical programs, and they require a long-term view. And these two factors are probably why there has not been enough funding allocated to NCDs. I'm not saying replace the infection disease funding with funding for NCDs. We need to remember, and COVID has definitely reminded us of this, that NCDs and infectious diseases all require adequate funding. And this needs to be a major, major focus, because without funding, we can't get very far. Sorry, I'm just trying to move slide. So now just to briefly go on to the ethics of care. So one of the big questions that policymakers need to make decisions, and even physicians, are the benefit versus the harm of any intervention. And we know that if we don't cover NCDs through universal health coverage, there is an increase in catastrophic health expenditure if people do try to access, or they die if they can't. So definitely we need to try to preserve health and life and improve access to NCDs under universal health coverage. We need to also respect the autonomy of patients everywhere and respect their dignity, reduce their suffering by improving access to care for all diseases. The problem is that, as was mentioned in the very first talk, there are problems of budget, and governments need to set priorities. They need to try to understand which priorities do we cover first. And often individuals obviously think their own personal health needs to be prioritized, but governments have to decide, how do we balance the health of an individual and the health of society, and think about social justice and solidarity to try to deliver the best possible health care for the most people. The idea of the right to health, however, involves a progressive realization, and therefore the right to health means one should get the best possible care available at the time, but governments need to commit to improvements over time. And then if the government is making decisions that certain diseases will not be covered initially, they need to be transparent. They also need to be accountable for their decisions so that they are fair. And one of the big issues is that conflicts of interest need to be declared. And unfortunately, sometimes there is corruption, and there is also agendas driven by industry or by research, etc., which may not be in the primary benefit of the community. So just very briefly, when we think of minimal health packages, we think we want to give each person, as on the left here, the exact same box of health packages. But unfortunately, when we come to non-communicable diseases, things are not as easy, and each person has different requirements. So if we think of equality, we offer everyone the same package. If we think of equity, which would be what we should strive for, we are able to assess each individual's needs, and then hopefully the health system can provide whatever is needed for that person, such that each person gets an equal opportunity for health and well-being, and in this case, to watch the baseball game. So basically what we need to think about when we're thinking about ethics and non-communicable disease, we need to remember that we need to have respect for all. And in the health system, equity, sustainability, quality, accessibility, and acceptability are all ethical imperatives and absolutely crucial. As Dr. Kalia Sebula really showed, the value of setting priorities locally with the community providing input as to what for them are important. And then we need to try to avoid imposition of external agendas for research and clinical programs so that the priorities of the local communities are actually met and the needs are understood, and these become the goals, rather than having external groups coming in and dictating what should be done. So just finally, in conclusion, I think we need to acknowledge the reality of the NCD burden if we are to try to tackle it. We need equitable funding for NCDs, similarly to infectious diseases. Probably we need better funding for both. We need a commitment to sustainable and quality service, and we need a commitment to holistic prevention, including all the social determinants of disease, to try to reduce NCDs. And ultimately, governments need to commit to progressively realize the right to health for all, and this is all people, including the most vulnerable in rural areas, as well as all diseases, even those that are very expensive to treat. And so the bottom line is, it is now time to deliver on NCDs, and we need to continue to advocate and push for this important agenda. Thank you very much for inviting me, and I also will be very, very happy to take questions.
Thank you, Dr. Likes, for this excellent final wrap-up with ethical implications for sustainable NCD management. We are now moving to the questions that have been raised. I noticed that 2 of them have already been answered by the speakers, but there are 2 questions that we still have. One is directed to all the speakers about how we can achieve an ideal collaboration between government policy, civil society, research, and private sector. What would this look like in terms of strengthening the healthcare in the rural areas? So this is directed to all the speakers, and you feel free to comment on that. How do you evaluate the universal health coverage implementation for non-communicable disease care, particularly cancer care? This is, I think patients in poor countries are suffering from the catastrophic expenditure, and at the same time, many are dying due to lack of affordable care. I'll request Dr. Mutunji to comment on that since he's the Assistant Commissioner in charge of NCDs, but we can also have a comment from any other speaker on this. So we can take the question that's directed to all the speakers, and we can move in order of the presentations as we started for each speaker to take a minute and respond to that, and then the rest will add to that as we move along. So we can start with Dr. Mutunji, if you'd like to comment on that and also answer the question that was directed at the cost of care, and then we'll move on to the rest of the speakers. Next will be Jackson. Thank you.
Thank you very much, Professor. I think collaboration, yes, for us here, we take collaboration as very, very important. We have actually established a department for partner collaboration to coordinate all the partners, because we know we can't do this alone. We can't provide healthcare alone. The civil society has a role to play. The academia has a role to play, and others. Even actually in our technical working groups, we have all the stakeholders, including the academia, the civil society, and others. So I don't know how best we can do it, but I think that is one of the ways that we involve each other in all our undertakings. I'm happy the academia now, when they are writing research grants or doing studies, they also involve policymakers, so that whatever we find in the academia can influence policy and benefit the population. So that's how we are doing it here at the Ministry of Health. And my colleague who asked the question about cancer and that many people are dying of cancer, it's true. I agree with you. Many people are dying of NCDs up country because it's expensive to treat NCDs, especially cancer. But what we are doing is that we are trying to decentralize cancer services to our regional referral hospitals here in Uganda, so that already Mbarara in the southwest is working. We are trying Arua, we are trying Mbare. So something is being done to bring cancer services closer to the people, but I agree it's not enough yet. We should take it further because many people cannot easily even access referral hospitals. I think it is an unfortunate reality on the ground, but we are not sitting, we are trying. If you have any ideas how we can do it better, you are welcome. Thank you.
Thank you, Dr. Mutwenje. We are moving on to Dr. Jackson. A quick comment on the question that was sent to all the speakers.
Sure. Thank you so much for asking that question. I think it's a very good one. I think if I had the answer, then you know, we would be able to really solve things. I think, you know, in a lot of ways, I think the first step is hopefully meetings like this. I think getting people together that have different backgrounds, like Dr. Mutunge and others who come at this from different directions, and you know, our representative from Gilead, that's sort of the crux of it, I think, is to try to involve private industry, policy, and hopefully ultimately kind of increase funding and have collaboration with each other to learn from one another. I'm not sure exactly what the perfect model is, but I do think that, you know, those steps are going in the right direction.
Thank you, Dr. Jackson. Dr. Kalia, any comment on this? And as we go along, I'm also intrigued by some of the complex challenges that you've been presenting. And I see that, yes, we are talking about health promotion and prevention, but it looks like many of our conclusions are skewed towards improving clinical management. And I get the sense we are not about to treat ourselves out of NCDs. So we need to hear perhaps more about this area. And also, especially looking at the other sectors and disciplines, we're talking about the complex issues of biomass, for example, as an exposure to obstructive disease. But we know that we also have to touch the issue of having safer, you know, energy to use for cooking beyond dealing with the clinical aspects. So I hope I can hear a comment around these issues as well as we think about the collaborations. How can we bring in people outside health, outside medicine, to ensure that our interventions are more comprehensive? So Dr. Kalia, a comment from you, but if for the subsequent speakers, if you don't have a comment on partnerships, at least you can comment on how we can expand the scope of partnerships to also deal with health.
Thank you very much.
Thank you.
Yes, thank you very much, Professor. I think the issue of collaborations, you've actually touched on a very good issue, and I'm sure Professor Likes actually talked about it in our previous discussions of it's much easier to do promotion and prevention than treatment. And I think this requires a multi-sectoral approach. And I think being that we are clinicians, sometimes we tend to skew ourselves towards the medical treatment, which I think is just the tip of the iceberg. So among the collaborators, really, we need the government. It has to play a key role. And we are very happy that Dr. Mutungi is at the helm of this. They have a non-communicable technical working group, which actually is all encompassing. It has nutritionists, it has environmentalists, it has health promoters, and that's where we begin. But then ultimately, we need also to involve the community members. And as I presented earlier, we have actually a community advisory board that actually also includes part of the multifactorial, because they are the consumers of whatever we are trying to bring in. For the time being, I'll stop there, but because I know we are caught for time, but I totally agree with you, Prof, that this needs to be multifactorial. Thank you.
Okay, thank you, Dr. Kalia. Dr. Nasa.
Yeah, thank you very much. On the question of collaboration, I think it's very important to look at the solution from a horizontal perspective. That also holds true, despite all the successes for the Global Fund, different UN organizations, which were historically and for justified reasons focusing very much on treatment verticals. The community health worker and primary healthcare service delivery is at the core of where we need to look at, irrespective of disease verticals, because ultimately we treat people and not diseases. There needs to be an increased domestic ownership and also financing, really skin in the game. And I was very pleased to hear from Dr. Mutungi today what great achievements Uganda has already put forward. And last but not least, my sector, the private sector, has in the past very much focused on an attributive model, basically indicating always how great and gracious our contributions have been. It is important that we shift into a contributive model, working with partners and co-creating. Thank you.
Okay, thank you, Dr. Nasa. Dr. Likes, any comment on this?
Yeah, thank you. I think you touched on the actual crux of the matter, and I really do feel that even we as physicians need to admit that it is not all up to us. And I think stressing things like, for example, maternal education, girls that get to school, if there is equity and access to education, and a girl who's gotten to school has a greater chance of spacing pregnancies, has a greater chance of having healthy pregnancies, healthier children, having a higher income for her family. So the health of the entire family improves just with the little girl having gone to school. There are many other examples of how the various other sustainable development goals, in addition to health, can help with health promotion. And I think we also need to advocate that if we can improve health, we improve the workforce, we improve economic productivity. So this all needs to go together. And just my very last thing, I think, is transparency and working against corruption is critical, because I think, I agree the pharma industry has a lot to contribute, but I think it would be nice to know what prices are and a little bit of transparency about various things in terms of pricing, fair profits, these types of things, so that care can actually become more affordable on a bigger scale.
Thank you. Thank you, Dr. Likes. Since we have some two minutes before we wrap up, I will ask a last one to Dr. Mutungi. We see a number of shifts towards paying more attention towards promotion and prevention of disease, especially as we begin to emphasize universal health coverage. And just like we are speaking of more collaboration across disciplines, we need to see this across sectors as well in terms of policy and practice. And I'm specifically interested in hearing your perspectives in a minute or so in terms of how we can move from debates and policies on these issues to real action and seeing the money follow the disease patterns, and especially also begin to shift towards promotion and prevention. Where do you see this headed for Uganda?
Thank you very much. There are efforts in place. We've formed a multi-sector committee. We also have a multi-sector strategy where all the sectors we think are very relevant to prevention and control of NCDs are, for example, agriculture, education, finance, trade, all those formed a committee. And with the multi-sector strategy, each sector has strategies to implement, and we are lobbying that each sector plans and budgets for those strategies. Whether that will happen, we are yet to see, but at least I think it's the direction we are taking. And this is supported by WHO, and even UNDP is now coming on board. Hopefully something will come out. We shall lobby the Prime Minister's office, the budget, the parliament. Soon we are meeting the parliamentarians to lobby for the budget so that each sector is given money specifically for control of NCDs. For example, trade must restrict unhealthy products, must also label them and even restrict advertising, increasing taxes on tobacco products and others. All that we have started. Whether it will actually actualize into money flowing into that area, we wait to see. Thank you.
Okay, thank you very much. There is also a comment in the chat here. I think that for the rural level, we need to have extension of workers in each and every parish and sub-counties, and also to embed some of these programs into the schools right away from primary to university. A lot of opportunities for educating our communities there. Thank you very much for that comment. I'll now hand over to Dr. Judith Van Housinger to do the wrap up. Thank you to you all speakers.
Thank you, Professor. Unfortunately, we're already at the end of the session and we're running out of time. I still have 10 questions on my list and I will have to email them to the speakers. Thank you for the insightful contributions. I think this was very inspiring. Thank you also to the organizers of this event in the background that we haven't seen today, but who did a lot of work before this session today. Thanks to the participants that attended our session and for your interesting questions. I think we had a very good discussion. We hope that this session provided you with new perspectives and methods to strengthen universal health coverage in rural areas of low and middle income countries. We also hope that you will continue to enjoy your time at the World Health Summit regional meeting in Kampala. This time it's digital. Hopefully we'll meet next time in person. And we hope that you will have many opportunities to discuss new ways of strengthening global health for everyone, also on the other panels. Thank you for joining us today on a Monday morning. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you.
So, Professor, I hope to meet you in person sometime.
Sure, I do.
Maybe next year when we're allowed to travel again.
Sure, looking for the opportunity to meet in person as well. Yeah.
But it was good meeting you online today. Thank you. And thank you, Rebecca, for organizing.
Thank you both for the great moderation of the meeting. That was very nice.
Well, you had all the work and I hope you now have the chance to relax a bit.
Yeah. Now it's successfully over. Thank you. Have a nice day.